Welcome to Physiology class. Today we are discussing about the topic deglutition. So as we all know, deglutition is swallowing is a process by which food moves from mouth into stomach. So deglutition occurs in three stages: the oral stage, pharyngeal stage, and esophageal stage. The deglutition or swallowing refers to the passage of food from the oral cavity into the stomach, and it comprises three phases, namely oral stage, pharyngeal stage, and esophageal stage. Moving on to different types of stages in detail. For that, we have to discuss about the innervation. So, innervation or swallowing is by vagus and glossopharyngeal nerves for upper one third, and vagus nerve innervates the lower two third. It is the structure of the Pochat cord innervation from the brain stem, the medulla and pons. The swallowing center is located in the medulla and pons. The nerves are innervating. Swallowing can be divided into first voluntary stage of swallowing, that is oral phase, or the first stage of swallowing. During this phase, the bolus of food formed after mastication is put over the dorsum of the tongue. The tongue forces the bolus into the oropharynx by pushing up and back against the hard palate bolus, which voluntarily skews or rolled posteriorly against the palate. So, the tongue forces the bolus into the oropharynx by pushing up and back against the hard palate, and bolus voluntarily skews or rolled posteriorly against the palate. Swallowing can't be stopped in this stage. Moving on to the second stage, that is pharyngeal stage of swallowing. As we discussed, the oral phase as a voluntary stage, but the pharyngeal stage of swallowing is an involuntary phase. Pharyngeal phase or second stage of swallowing is an involuntary phase. Bolus reaches posterior mouth and pharynx. It stimulates the receptors. So the receptors initiate series of automatic pharyngeal muscle contraction. Here is the arc, which the components are receptors, afferent arc, deglutition center, and efferent arc. So the receptors which are present around the opening of pharynx, especially over the tonsillar pillars, are stimulated when bolus moves from the mouth into the pharynx and initiate the reflex activity. So the receptors which are present at the opening of the pharynx are stimulated when bolus moves from the mouth into the pharynx and initiate the reflex activity. The afferent arc that carries impulses from the receptors to the deglutition center comprises the trigeminal, glossopharyngeal, and vagus nerves. The deglutition center, which coordinates the reflex activity, is located in the medulla oblongata and the lower pons, that is in the nucleus tractus solitarius and the nucleus ambiguous. So the deglutition center coordinates the reflex activity, which is located in the nucleus tractus solitarius and the nucleus ambiguous. Then the efferent arc, which initiates a series of muscular contraction, reaches the pharyngeal musculature and tongue through the 5th, 9th, 10th, and 12th cranial nerves. So these are the components of the arc, which comprises of receptors, afferent arc, deglutition center, and efferent arc. Moving on to the events during pharyngeal phase, the oral cavity is shut off from the pharynx by the approximation of posterior pillars of the fauces. Then the nasopharynx is closed by the upward movement of soft palate, preventing regurgitation of food into the nasal cavities. Then comes the palatopharyngeal folds, which are pulled medially to make slit-like opening for food, allowing only properly masticated food to pass through. The vocal cord strongly approximates, stopping the breathing temporarily, that is called as deglutition apnea condition, and the larynx is pulled upward and anteriorly by neck muscles, enlarging the opening of esophagus, which is normally a slit, and epiglottis swings backwards to close the laryngeal opening. So in case of vocal cords. Vocal cords strongly approximate, stopping the breathing temporarily. And the larynx is pulled upward and anteriorly by the neck muscles. So the neck muscles are get enlarged. The opening of esophagus, which is normally a slit, and the epiglottis swings backwards to close the laryngeal opening. All these guide the food towards the esophagus and prevent its entry into the trachea. Upper esophageal sphincter, which normally remains contracted tonically, opens up and allows the bolus of food to be pushed into the upper part of the esophagus by the rapid peristaltic contraction wave of pharynx, which also continues in the esophagus. Once the bolus of food has passed into the esophagus, the cricopharyngeal muscle contracts and vocal cords open up, allowing normal breathing to be resumed, and the upper esophageal sphincter once again goes into the tonic contraction. The entire process of pharyngeal phase is completed in 1 to 2 seconds. About the automatic pharyngeal muscle contraction, the soft palate is pulled upward and prevents the reflex of food into the nasal cavity. Then palatopharyngeal folds are pulled medially to approximate each other, form a sagittal slit. Then vocal cords are approximated. Larynx is pulled upward and anterior by the neck muscles, and the epiglottis swing backward over the opening of larynx. So here we can see the vocal cords, trachea, esophagus, laryngeal structures involved in the deglutition. The bolus of food is moved through these parts. Upward movement of larynx and enlargement of the opening of esophagus occurs, and the upper 3 to 4 centimeters of esophagus relaxes. Then muscular wall of pharynx contracts to push the food downward by the propulsive contraction. So this stage is lasts for less than 2 seconds. Moving on to the third stage, esophageal stage. During esophageal phase, the food bolus is propelled from the upper part of the esophagus to the stomach by the esophageal peristalsis and aided by gravity. Before describing the features of esophageal peristalsis, it will be worthwhile to discuss briefly the applied anatomy of the esophagus, as we also already seen the structure of the deglutition parts. Esophageal stages following says that condense food rapidly to the stomach. Two types of peristaltic movements are the primary and secondary. So in the primary peristalsis, continuation of the peristaltic wave is occurring. It begins in the pharynx and spreads into esophagus and passes in 8 to 10 seconds. Continuation of the peristaltic wave begins in pharynx and spreads into esophagus and passes in 8 to 10 seconds. Secondary peristaltic waves results from the distension of esophagus. These are the two types of peristalsis which conducts food rapidly to the stomach in the esophageal stages following. So the secondary primary peristaltic waves begins if the primary wave failed to push the food down. Here is the upper diagram for upper esophageal sphincter contraction relaxation. Here the bolus of food, we can see the bolus of the food. From here, the upper esophageal sphincter is contracted. Then when the food bolus comes here, the upper esophageal sphincter relaxed and the bolus is pushed down. These are the different stages where the bolus have to pass. Receptive relaxation of the stomach. As the waves of peristalsis pass through the esophagus to the stomach, a wave of relaxation precedes the peristalsis, which is transmitted through myelin inhibitory neurons. The gastroesophageal sphincter is located above the junction of esophagus with stomach by 3 cm and remains tonically constricted. Peristaltic swallowing waves passes down the esophagus. Then the receptive relaxation of gastroesophageal sphincter occurs, which allows the food to go easily to the stomach. Sphincter does not relax satisfactorily. That condition is called as the condition in which the sphincter does not relax satisfactorily is called as achalasia. The bolus is swept along esophagus by peristaltic contraction. When the lower esophageal sphincter opens, the bolus moves into the stomach. esophageal reflex can be prevented by the gastroesophageal sphincter. That mechanism is called as wire-like mechanism. Here, a short portion of the esophagus that extends beneath the diaphragm before opening into the stomach. Thereby, the esophageal reflex can be prevented. Here, we can see the relaxed muscles, which the circular muscles contract, consisting passageway and pushing bolus down. So, the bolus is now here. Then here the circular muscles are contracted. The bolus is now here. The longitudinal muscles contract, shorten passageway ahead of bolus. Gastroesophageal sphincter is closed here. The stomach is located here. The bolus have to reach the stomach. So here the muscles are relaxed. The relaxed muscles, then gastroesophageal sphincter get opened. Then the bolus is pushed down to reach the stomach. There are some factors that contribute to the competence and tone of the lower esophageal sphincter. The lower esophageal sphincter is formed by the lowest 2 to 4 centimeters second of the esophagus, as we already discussed. So the lower esophageal sphincter is also called as the physiological sphincter, and the resting pressure of lower esophageal sphincter is about 50 to 25 mmHg. About the neural control of the esophageal sphincter is there are internal relaxation and external portion of sphincter relaxation. So internal relaxation, that is contraction cycling coordinated by the medulla via vagus, and external portion that is called as pleura, which is applied by the phrenic nerve. So two innervations by the vagus nerve and the phrenic nerve, internal relaxation by the vagus nerve and external portion by the phrenic nerve. Factors contribute in the competence of tonic contraction of the circular muscle fiber, oblique gastroesophageal angle, which forming the flap valve mechanism, and the pleura, external portion by the pinch cock mechanism, and the lower esophageal sphincter is intra-abdominal. Which enhances the lower esophageal sphincter tone is increased by cough phosphase and also by some actions of the hormones. Lower esophageal sphincter tone is increased by the hormones like gastrin, motilin, alpha-adrenergic stimulation, estrogen, etc. And is decreased by secreting glucagon, VIP, and GIP progesterones. So already talked about the gastroesophageal reflexes, in which acetic content of the stomach gets back into the esophagus by the chronic acid reflex. To prevent this, there are several mechanisms. Are the pinch cock mechanism, then prominent smooth muscles of the lower esophageal internal sphincter to prevent the reflex. Right close or the diaphragm is around the pinch cock like action on the esophagus to prevent the reflex. The flap-like mechanism helps to close off the esophageal gas rejection and by prevent the regurgitation. Then short portion of the esophagus by the valve-like mechanism extends slightly into the stomach, thereby preventing the reflex. Intra-abdominal pressure increases, which causes esophagus invert at this point. Then by the intra-abdominal pressure, forcing the stomach contents backwards into esophagus, preventing the forcing of stomach contents backward into the esophagus. Moving on to the disorders as following. First one is abrogation of deglutition reflex. So abrogation of deglutition reflex causes regurgitation of the food into the nose or aspiration into the larynx and trachea. It may occur when the 9th and the 10th nerve is paralyzed in lesions of medulla, and pharynx is anesthetized with the cocking. So deglutition reflex is abolished temporarily when the pharynx is anesthetized with the cocking. Moving on to the second condition, aerophagia. Aerophagia refers to unavoidable swallowing of air along with the swallowing of food bolus and liquids. Refers to unavoidable swallowing of air along with swallowing of food bolus and liquids. So it usually occurs in those individuals who have low tone of the upper esophageal sphincter. Some of the gases present in the air swallowed are absorbed, and partially the air is regurgitated into the oral cavity and out in the atmosphere. Out into the atmosphere, the process is called as belching, and majority of it passes on the colon and is then expelled as fatus through anus. Then gastroesophageal reflex disease, where condition in which incompetence of the lower esophageal sphincter causes reflux of the acidic gastric content into esophagus, and the reflux of the stomach acid causes esophageal pain. That esophageal pain is known as heartburn and may lead to irritation of the esophagus or bronchioles. The condition in which irritation or esophageal bronchioles lead to is due to aspiration. Then dysphagia. Dysphagia is term used to denote difficulty in swallowing due to any cause. The causes of dysphagia includes in oral condition, the painful mastication is occurred. The causes are oral malignancy, tonsillitis, herpes simplex, ophthalmic ulceration, stomatitis, etc. The pharyngeal causes following cerebrovascular disease, bulbar and pseudobulbar palsy, pharyngeal nystagmus, myasthenia gravis, motor neuron disease, pharyngeal diverticulum. The esophageal causes are motility disorders including achalasia, diffuse spasm, and scleroderma. Extensive pressure is caused by the bronchoornamental carcinoma, dilated left atrium, in aortic aneurysm, foreign bodies, and goiter. Intensive pressure by the carcinoma, left rings, oval esophageal ring, and meningeal esophageal stricture. Then achalasia cardia. The normal esophagus and the stomach is shown, and in achalasia cardia, the achalasia dilatation, the widening of the esophagus occurs, and the sphincter not working properly, and the bolus can't move into the stomach. So it's a disease of unknown etiology characterized by epiperistalsis in the body of esophagus and failure of relaxation of the lower esophageal sphincter on initiation of swallowing. The food collects in capacious esophagus, resulting in dilatation of the esophagus. Here is about the pathophysiology of the achalasia cardia. The initial result that is maybe viral. So myelin plexus inflammation occurs and it will inhibit the neuron destruction and causing achalasia. Also by the genetic susceptibility, the myelin plexus get inflamed and the anti-myotic autoantibodies, the entering of anti-myotic autoantibodies due to genetic susceptibility, inhibitory neuron destruction may cause and causing the achalasia. Clinical features are dysphagia, regurgitation, retrosternal chest pain. Investigation includes X-ray chest, barium sola, and esophagoscopy. And treatment, endoscopically, we can do pneumatic dilatation, botulism, and surgical method of removing. That's all about deglutition of swallowing.